the noises, Colicia? Do you even know all the noises? Like what's, yeah. Like that must be Eric walking on in. Yeah.
This meeting is being recorded.
So welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. Please note for the record that Sally Hernandez Piñero is participating virtually in a listening capacity, and Dr. Allen is representing Dr. Katz in a voting capacity. Bylaws Section 14, committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Sally Hernandez Piñero has requested that Erin Kelly, representing Ann Williams Isom, be counted for the purpose of quorum and voting on her behalf. The request was approved. So I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on May 8th, 2023. All in favor, please say yes.
Yes.
Opposed, say no. So minutes adopted. So next we will hear from Mr. Ziegler, Dr. Way, and Deborah Brown as they provide updates on the system dashboard. But I think it's you, right?
Yeah, it's me. All right.
Yeah.
Thank you, Dr. Pagan. So Matt Siegler and Deb Brown are out today, and so therefore Ali Noodleman and Deb Brown's team will provide our governmental affairs update, and then we'll go through our dashboard and the trends on the metrics. And then I'm going to turn it over to Dr. Nicola Davis to provide a deeper dive on our hemoglobin A1C. So if we could go to the next slide, please. Technical difficulty. All right, so it goes to Ali, right?
Great. My name's Allie Noodleman. I'm on the External Affairs team, and I'm going to provide a brief government affairs update. On the city level, Election Day was November 7th last week, and the entire city council was on the ballot alongside other citywide officials. Nearly all incumbents held onto their council seats. On the state level, the New York State Division of the Budget issued its mid-year report and indicated that the state deficit has been reduced from $9.1 to $4.3 billion. The state budget director said publicly that the governor does not plan to roll back new investments in school foundation aid, support for hospitals, or mental health to make up for the budget's shortfall. And as of November 16th, there are 165 bills that passed both houses of the state legislature that still need to be considered by the governor before the end of the year. On the federal level, last week, Congress passed a continuing resolution to keep the government open into 2024, with one tranche of government funding now expiring on January 19th and another on February 2nd. The Medicaid DSH cuts were delayed until January 19th. We will continue to advocate for the DSH cuts to be eliminated, and there's broad support for doing so. Thank you.
Thank you so much. Any questions?
Can I ask a question? On the DSH cuts, is it just going to be tied to the CR, you think, or are they going to actually try to do us something that changes, extends them?
I hope that it will be a more permanent solution. Previously, they've done a 1-year delay, and it's been separate policy. So I think it depends whether there's any flexibility to add anything onto omnibus spending bills, or if they're just going to be doing CRs until they can kind of figure their stuff out.
But we don't see any reason to think they won't continue.
No, I think Senator Schumer has been very vocal that the DSH cuts won't happen, or at least as tied to the federal funding debate. So I think we're cautiously optimistic.
So thank you for the updates.
We'll go to the next slide. So I'm going to take us through our usual, metrics that are trending positive, and then staying kind of neutral, in those that have trended in the wrong direction. I will say overall this was a very positive quarter, April through June 2023. A lot of green on our dashboard, a few red, surprisingly no yellow. But starting with some of the quality and outcomes strategic pillar, our follow-up appointments kept within 30 days after behavioral health discharge improved 1%, almost 1%, from 50, or sorry, 51.7 to 58.1%. And speaking to our behavioral health leaders, Dr. Omar Fatal, what's really encouraging is that over a third of our sites are over 60% on this. So we have some best practices and a lot of work with those who are below the average and moving them up. And so that was the big jump there. Our hemoglobin A1C, which we'll do a deeper dive, kudos to Nicola and her team. It's been at a system record and it just keep going up, right? So 68.5, now 68.8. Our percent left without being seen in the ED decreased slightly from 4.8 to 4.7. That's still above our target of 4%. This is sustained 20-25% increased volume that our EDs are seeing post compared to pre-COVID. And so we're struggling to figure out how to handle that volume. Our post-acute all-cause hospitalization did decrease from 2.5 per 1,000 care days to 2.4. So that's Dr. Coy Long and his post-acute team and their hard work on preventing unnecessary transfers to our emergency departments there. Go to the next slide. Oh, Rita, you have a question?
This is great statistics, and I'm just curious if there's any, I guess it's more about how we set these targets. We're doing really well relative to them, but kind of benchmarking to, industry standard. I'm not sure what the appropriate benchmarking is, but
Yeah.
do you guys have any standards for that?
So once a year, we're adjusting the entire dashboard for targets. And that's when we're also, discussing should something be retired and replaced.
Okay.
And then throughout the year, if we've hit it in the first quarter and we're sustaining above it, then we'll adjust the target accordingly. We do look at current performance. We do try our best to look at benchmarks, and Hillary's done a lot of hard work with Premier as our vendor that allows us to benchmark across the country, but also looking, what is the mean across the system and setting kind of SMART goals, right? 10, 15% increase or decrease, depending on. So it's a combination of those two things. I could say for the left without being seen from the emergency department, 4% is kind of a target for academic center across the country. And so that's why we set that one. 2% for community hospitals.
I see. Lower in community hospitals.
Yeah.
Great. Thank you.
Okay, we'll go to the next slide. All right, so moving to our care experience pillar, we've seen an improvement in the ambulatory care from 85.9% to 86.4%. That's still a little below target at 87%. And our inpatient care, which is the top box score overall rating, also improved from 62.6 to 63.9. Still below target of 66.3. And so these targets do come to us from Press Ganey. They look at their whole database and they set targets for us. The culture of safety pillar, our total wellness encounters, as a reminder, these are H3 debriefs, one-on-one, group debriefs, wellness rounds, retreats. They improved from 586 the previous quarter to 728, and that's well above the target of 600. Go to the next slide. So for our financial sustainability, we also have positive trends in many of them. So our patient care revenue over expense ratio, 77.9%, which is up from 73.8, and that's well above the target of 65. Our total accounts receivable days did move in the right direction, 48.4 to 47.4, so it took off a whole day, but some work to get to our 45-day target there. And then I know we just had our MMPA and EITS board meeting, but the Enterprise Data Center migration is on track as of June 2023. 93% of the overall body of work is complete. And the transition from SunGard to QTS is 100% complete at this point. Okay, next. And then finally, our access to care. Continue to see NYC care hit record numbers, 119,000, up from 116,000 the previous quarter. This is above the target of 100,000. And then our unique primary care patients improved to 427,000 from about 424,000, which is also above target. All right, so these are the ones that trended in the wrong direction, but are better than or close to target. So our MyChart activations continues to kind of slowly decrease from 58 to 56%. This is below our target of 60%. So we did see record numbers when we did use COVID testing results as a driver to send people to MyChart. It is really high for our enrolled and primary care patients, but there's some more work in the other settings. And so there is a MyChart steering committee that's looking at this and coming up with new kind of interventions on how to re-enroll or keep people enrolled, activations there. For our post-acute AR days, it trended 1.5 days in the wrong direction from 48 to 49.5. Still just below the target of 50 days there. And our number of e-consults dropped a little less than 1,000, but still much better than the 95,000 target there. And I think that's probably just, common cause variation, right? Did we have reasons to use e-consult? Next. And then on our financial sustainability, this is the percent of uninsured patients enrolled in health insurance coverage or financial assistance dropped slightly from 80% to 77%. Speaking to our finance colleagues, we had some staffing challenges at a few of our facilities that are already resolved or will shortly be resolved in order to get all patients screened as we usually do. And then percent MetroPlus medical spend dropped from, or MetroPlus medical spend at H&H dropped from 46 to about 40% there, and that had something to do with the risk pool. But we're paying close attention to
Are you
that.
able to explain that? I saw that in
Yeah.
the footnote.
Yeah, I mean, I think it's a bit of a timing thing, and actually the 46.4% was almost a little bit of an outlier on the high side, but there is sort of timing as it relates to the risk surplus that MetroPlus receives and some of the sort of primary care spend, and so it's a little bit of a noisy metric we want to work with MetroPlus a little bit more, but the reason for the big drop is much more timing than really anything else.
So the percent MetroPlus medical spend at health hospitals, what does that actually measure?
That measures essentially of the total book of business that MetroPlus has, how much of it stays within the H&H system. So essentially, for patients, do they end up going outside of our system for any care, or
So when you
part of that
say
care.
risk pool, what do you?
So the risk surplus is sort of, or the risk-based arrangement we have with MetroPlus being full risk, essentially any spend that they do that is above what they receive from the state from Medicaid in terms of an overall per member per month payment, that would be a loss. Any savings they have would be a surplus because we sort of own them and we have the full risk capitated arrangement. We get to keep that benefit, but when the benefit decreases, less money ends up coming to H&H.
But so that benefit is only attributable to MetroPlus members that are within our system. Any MetroPlus members that are outside of our system, the surplus goes to.
No, so the surplus would still come to us.
So does this count the surplus from other members too, or it's just?
This should count the surplus from all members, but I think because when folks go outside of the system, if we have both the medical spend and the surplus, we sort of get the benefit of both.
Right.
When we lose the medical spend, and sometimes if folks go outside of our network or the system, the spend is more expensive, whereas we might have better rates with them or better arrangement. There ends up being less dollars than.
So this
available.
metric doesn't really measure how much of MetroPlus members we keep in our system. It's more just the dollars that we keep from MetroPlus.
It's both. I think it's both.
Yeah.
Because on the front end, like we want to have all the patients on the front end, their medical spend, and then there's also the piece on the back end. But I think we should. I mean, I think the larger share of all the dollars come in through the medical spend. So really keeping more patients inside the H&H system will improve this metric the most.
Okay.
That was the intention of this metric. is
Right, that's what I thought the
to
intention was, but the
increase,
risk pool comment kind of confused me because it feels like, but there's a little bit of both in those, and the timing of that is creating some of this volatility, it sounds like, and so,
Yeah, and actually we're planning, we want to revisit the metric with Metro Plus in terms of how they calculate it on a timing basis,
Okay.
because as you'll see over the last few quarters, it's bumped from
Bumping
46,
around.
43, 39. It kind of moves
one-
more than you'd expect.
The one that matters from our perspective is the definition that is exactly what that says, which it would be like how much they actually spend, right?
spend and not the
Yeah,
risk
that we
pool.
have access
That
for
we,
our patients.
yeah, that they
to
come in,
here.
get care here, they, you know,
Exactly.
Yep.
Right, that's what I thought.
not anything else.
Right, the other stuff creates noise.
Yeah, yeah.
Mhm.
So we do want to revisit the metric.
Okay, thank you. And Eric, you said you sort of revisit the dashboard annually. When does that happen? At the beginning of the
I
fiscal
think
year?
it's the
or-
first quarter, right?
Yeah,
Yeah, so it's the
coming
next
up,
one. It's the next one.
next one.
Okay. It'd be good to have a kind of a brief, yeah, on that.
Yeah,
That'd be
absolutely.
Thank you.
Okay, so these are not the strategic pillar, but our foundational racial and social equity. So this first one was percent of new physician hires being from underrepresented minorities in medicine, and so you could see the numbers are still bouncing around quite a bit. But we have seen a significant decrease in the unknown, which has been a big sort of push with our affiliates, and collecting that when we're onboarding. It used to be in the 60% plus that were unknown. January through March, we got all the way down to 10. Right now, it's 24.5%. We see that our women went down a little bit from kind of 2022, where we're in the 40% down to 20%, and then now 24.4%. Our non-binary is 0 over the last 4 quarters. AAPI also decreased a bit from kind of quarter 3, quarter 4 of last year, down to 9.3% now. Our Black or African American has bounced around from 4s to, we had a 8%, and then now back to 4.1, and our Hispanic Latino 1.9%. And so, I think it's hard to tell if there's a trend yet until we really get the unknown down to under 10%, single digits, consistently. But we'll keep tracking this and keep working on it. Michelle?
Do we have this broken down by facility?
We can. We don't have it in this slide deck,
Mm-hmm.
but if that's helpful as a appendix, we can do that. I think the numbers will be relatively small when you slice it out, but if we add them all together for like a whole year or something.
When,
And
Can
I mentioned
I-
this before, can we balance this with, so these are the new hires, can we balance it with the people who exit?
Yeah.
The demographics of who's leaving, because it looked like, just looking at Asian, Blacks, and Hispanics, October through December 22 was a high
Yep.
quarter. And then what happened?
Mm-hmm.
Why did the numbers go down? So,
Yeah.
thanks, Eric.
I do think, Michelle, that looking at the levers too is very instructive because sometimes the retention is the hardest part.
Yeah.
Yeah.
Yep.
So maybe some of this, it balances out the data in
Yeah.
some way, or makes it look worse. One or the other.
Just an anecdote from Elmhurst Hospital. I'm Damien Archbold. I'm an anesthesiologist at Elmhurst. In the last 2 years, we've had 2 amazing fellowship-trained African-American women doctors who left because of the volume of involuntary overtime and also their sort of inability to have part-time options. They both had young children, couldn't leave, so they both left. So at the moment, out of our 20 anesthesiologists, we don't have any African-American women. They both left, and it was
Yeah.
a challenge with retaining them.
Right.
We had a director who recruited them, but they couldn't stay because they couldn't
lack of
have,
flexibility.
have reasonable working conditions.
Okay. So we'll bring that back for the next
Do
one.
we do exit interviews in cases like that, human resources, just so that they can document what was just described?
I think it is a recommended best practice across the system, but the performance of it is variable. We don't
Or
have
something?
documentation, right? Like it's a good practice for chiefs and for nursing managers and directors to meet with folks who are leaving.
out
I
where
meet
people
with
are
everybody
leaving.
who's leaving from my team, but there's nowhere to like document it and right. How are we collecting that data across patterns and
And then on the unknowns, this is voluntary information that is provided by the person when they're hired. So,
so some of
you know
it.
why it would vary a whole lot across different
I think it's the
affiliates and
same
so
thing
on?
as when we were trying to apply equity lens to our patients. If it's not emphasized, right, then people don't try very hard to collect it, right? They'll just move past it. There are, you know, as Michelle has pointed out many times, there are kind of um, people who come from different backgrounds who is like none of these truly capture me. So making sure that we have the right race, ethnicity, you know, using the census data, not just kind of the generic, right, three options. Um,
You got a PI project there.
yeah, yeah, no, we have a PI project. And so, right, how much are our affiliates, how much are we for the few H&H physicians that we hire, really making sure that space isn't blank, or if it's unknown, like really asking, like, is it because you feel like these don't capture you? Or there, right, would it be better if we had more options, or what option would you like to see? I think that's the work that needs to happen there.
Thanks.
Okay. And then this one we're really, really proud of. And I know those who come to QAPI see this. So the number of equity lens applied to performance improvement projects with data, our goal was to have over 40 per quarter. In quarter 3 of 23, we had 73. In quarter 4, we had 70. So these are PI project one-page summaries that are making it into our QAPI reports. I know on this one, Michelle and Nicole and Natalia have continued to nudge us, and we want to keep evolving it. You know, it's nice to have one, and that was a start. But do we want to have a standard kind of race, ethnicity, primary language spoken applied to all of our PI projects? And then the fourth one could be that, you know, applicable one. Is housing status more applicable, or, you know, payer status, or substance abuse, mental health? Um, and so that will be a 2024 goal that we now, it won't fit on our one pager anymore if we do 4, but we'll have a separate slide behind the one pager that is just the equity lens. And then not on this one, but really liked how Jacoby had a sustainability lens on their project this last quarter. And so we're in discussion, should we be looking at, you know, tons of CO2 saved on certain PI projects. But we want to continue to evolve here. But this was beyond kind of our goal. We almost doubled our goal. Yeah. So, not much to say on our COVID-19 metrics besides that a few, right? 2%, 4%, 7%. So nothing even close. The antivirals, we did see a increase from 6,000 to 12,000. That's because we continue to do our virtual express care Paxlovid service. And then the infusion treatments for those who are not eligible for Paxlovid, we did 1,400 in that last
So-
quarter.
Eric, this decline you just think is because of the COVID activity, and it doesn't have to do with who we're seeing or accessing.
Yeah, no, I think it is that people have gotten the disease, people have gotten vaccinated and boosted, and then the virus has evolved
Yeah.
to be kind of, we're not seeing as many hospitalizations and deaths
Mhm.
from it,
Great.
but we are seeing staff right, having to go out for it.
Mhm.
So Eric, on the previous one, on racial and social equity measures,
Yes. The lens.
the lens, that's, I'm sure it's hard to fit everything into one, we see it as one page, right, in the corner. There. I like, one thing I've noticed when we have those discussions is how it forces, I imagine that it forces the team to think about this angle by just the fact that they have to report it in that corner. So I don't know. So you're thinking about like saying preset the categories, but then
So what we're thinking of,
justify
of expanding that section, like it won't fit on our A3 summary anymore, so it'll be the next slide. But for every project, we want them to filter the outcome measure, so whatever their SMART goal is, by race, by ethnicity, by primary language spoken on every project, and then any additional ones that are more pertinent. Because right now we're just like pick one that you think is the most pertinent to it. But Michelle has expressed that she would like to see race, ethnicity, and language for all of them because it's pertinent to all of our PI projects. And then if there's something else, so probably four little squares that will show the outcome measure broken down.
So that would be like a second page, like a
It'll
second
be a
slide.
second page now.
Okay.
Yeah. And then, right, the continued evolution is we don't want this applied after the fact to be like, oh, it's too late, right? Like we identified a disparity or a disparity got worse, even, that would be the worst case. But it's too late to do anything about it now. We want it in our PI charter when they start thinking about the project that they're collecting it as they're collecting their data points and adjusting
I think that is a key point because what we get to see is, oh, at the end, they find out, and then they tell you in the plans, we're gonna do something about it.
Yeah.
But,
So you want it during the project, and then the next evolution that we hope is that any disparities left over at the end of the project, the next project has that as part of its aim statement. So equity kind of focused projects, like the goal is to close this disparity, right, that we identified in the last project.
the other part that I'm sure you have to deal with is the tendency to try to put cram as much as they can in one, like in the, because driver diagrams, you're trying to do 3 or 4 things, not 7 or 8, and it becomes really, I imagine that if you're doing the project, it becomes really hard to pinpoint what's driving the change, right?
Yep.
But what I can tell you is I've seen a huge improvement from the first ones that we would get to like where we're at now, that it's way out there.
Yeah. A lot of that credit goes to Hillary and the capacity building that we're doing across the system. I know Natalia's doing capacity building, and it's all of us mentoring fellows and people in the Quality Academy. So.
And I think there's a modicum of discomfort when talking about race. People aren't necessarily comfortable or at ease, and it's taken some time. I would like for it to be just part of our normal conversation, like what was the weather like today? What's the racial and ethnic distribution of the patients that we're looking at, whatever the PI project is. My desire is that we, as healthcare providers, recognize race and ethnicity, the disparities, and confront it face on. I did want to say the Office of Population Health at NYU Langone gave a lecture on how to define ethnicity, and it was really fascinating, especially among the Latin Hispanic population, because you could be Afro-Cuban, South American, Venezuelan, from Spain. There's just so many different variations of ethnicity within that particular single ethnic group. How do you epidemiologically make a comment or observe or document differences in care?
Yeah, that's tough. And
Okay, I want to make sure we give Nicole enough time, so we're gonna move to our deep dive here. And so at previous meetings, the question has come up like, how did we rebound and not just rebound, but go above and beyond what we were pre-COVID. And so we thought we'd bring the person who's responsible for this improvement to tell you how she did it.
I did it all by myself. Yeah, right.
Take a lap.
Nicole is a force.
Good morning, everyone. So happy to talk about the improvement of Health and Hospital in terms of diabetes control, which you will see has been a massive team effort across Health and Hospital. So I'm just going to talk a bit about our diabetes control trends, the standard of care that we have for our patients with diabetes, some of updates and some of our new programs that we have, and also what's next for diabetes. So next slide, please. So this just shows us the trend that we've had in diabetes control. So pre-COVID, our rates of control were about 66.5%, which was actually a high for us. We really took a nosedive during COVID, went as low as 60%. And we've continually rebounded since then. And now we have the highest rate that we've ever had at our institution, which is 68.7%. Next slide, please. So, so the prevalence of diabetes and hypertension are really high among our primary care patients. So for diabetes, our prevalence is about 27% throughout our health system, which is really, really high. And since 2022, as I said, we've achieved real improvements in our control rates for both. So we have more than a 3% improvement in diabetes control and over 4% in our hypertension control. And there have been lots of programs and efforts throughout the system that has really contributed to this success. So the foundation of the work that we're doing in diabetes, it really anchors on having knowledgeable primary care providers and clinical teams. So some of the programs that we've had, we have chronic disease RNs. Now these are nurses that are in our practice that dedicate about 50% of their time to population health activities. And so they really help to lead the facility diabetes initiatives, and they're in primary care. We have a chronic disease management tool that our office puts out, and this really provides patient-level data that helps the facilities to track their patients. And we do this both for diabetes and hypertension, but of course today we're focusing on diabetes. And it allows our teams to really have targeted patient outreach, and I'll talk a little bit more about that. We have a Treat to Target program, which we've had probably about 7 years now, I would say. And this is a system-wide nurse-led program. This is, again, our nurses in primary care. Many of the nurses that work in the Treat to Target program are also our chronic disease nurses. And what they will do is they will see our patients intensively who have uncontrolled diabetes or hypertension. They will have targets that they've set with the primary care provider, and then they will see the patient in between the provider visits in order to focus on lifestyle or medication management, anything like that, to really help the patient to achieve their goal. And we also have outreach buckets, which really allows us to do proactive outreach to patients that have uncontrolled diabetes, or if we notice that they don't have a scheduled appointment. So it really allows the facility teams to be very proactive in the care of this patient population. Next slide, please. So as I mentioned, we've had Treat to Target for a very long time, but in 2022, we undertook a pretty significant build in Epic that really helped to standardize the workflows in this program, and it allowed us to develop some new tracking and reporting tools. So what this has helped us to do is have even more referrals into the program. So we have about 3,000 to 4,000 patients across the system that are referred into Treat to Target. And since the launch of Treat to Target, we know that patients who have completed Treat to Target have had a significant reduction in A1C of about 1.7% and a significant improvement in their blood pressure as well.
So this is amazing. So what you described on the prior page, the standard of care, that continuum, that's so we identify a patient, a primary care patient of ours that has diabetes, and we proactively reach, because like they're not going to come in and make appointments and things like that. So we're actually, is that what you're
Yes,
describing
so
here?
yes, so we have primary care. We have a registry of all of our patients that have been in primary care that have diabetes. Now, many of those patients have well-controlled diabetes, and they'll just see their provider. But we have that percentage that are uncontrolled, and we have to be more proactive with them. And so, for some of those patients, we might see that they're due to have their blood work done, and then we'll call them proactively. They don't have an appointment; they need to have their blood work done, or maybe they had their blood work done and we see that they're uncontrolled. That's another reason for us to proactively call them, bring them back in so they could see a nurse or sometimes a clinical pharmacist, which I'll talk about. So we plug them into any of these, or sometimes they belong to more than one program so that we can really just try to help them to
And
get
so
under
we're really able
control.
to do this because of, it sounds like the Epic tools that we're using and.
Well, we actually had a lot. We had everything here prior to Epic. We've now built but it was so labor intensive. And so now we've really been able to build them into Epic. So we've been able to refine the tools, make them much better, make the documentation much better, and the team being able to just kind of track and see a lot easier. So we've put a lot of our tools into Epic now, but we actually had a lot of this foundationally built pre-Epic. Good. So in just to as you were saying, the chronic disease outreach. So lots of the new tools we launched. So we have two outreach buckets that are focused on patients who don't have an upcoming appointment. So those are patients who have an uncontrolled A1C in the last 3 months, or we see that their last visit was really so long ago, like 10 months ago, and then we really will aggressively try to reach them. So we have about 2 to 3,000 patients each month that are eligible for outreach. And so due to some of this streamlining of our workflows, we've been able to really prioritize our outreach and our completion. And so we're now increasing our completion from 25% complete to 50% complete. And that's multiple contacts with the patient to try to get them into our office. We also have collaborative drug therapy management pharmacists, and they can prescribe medications, and they're also knowledgeable in multiple chronic conditions such as diabetes. So they have been incorporated into all of our acute facilities as well as multiple Gotham sites over the past several years. And they can optimize medication regimens, and they all use predetermined diabetes algorithms, medication algorithms, which our office publishes. And so they're able to use that to guide the patient care. Next slide, please. We also have health maintenance topics that we've built into Epic. And this really just allows for the care team to have alerts during the care that they're providing. So it doesn't really interrupt their workflow, but it's something that they see in their natural work. And so we've released it that that promotes A1C screening, as well as identifying patients with diabetes who need a follow-up A1C. So these are now alerts that go to the providers as they're seeing patients. Next slide, please. This is just, it's hard to see, but it's hard for us to see when we're in Epic as well. But this is an example as to what the screen looks like. And so this is someone that has diabetes, and this would pop up for the provider that just kind of, you can make it out like when the A1C would be next due. And if it's overdue, it would be in red. And so this really just helps to promote that follow-up in terms of all of the screening things that our patients with diabetes need.
Color coding helps.
Yes, it does. It does. So what's next for diabetes? So we have a really audacious goal of 70% control, which is really high and something that I never thought we would even be thinking about. So it's really great to see that we're even approaching that. And we've updated the registry, our diabetes registry recently. And so it's really going to allow us to provide even more timely data to our facility teams. And what I'm really excited about in our new registry update is we have medication data in a real meaningful way so that we can now look to see what are real prescribing patterns The medications for diabetes have changed a lot over the years, over the last, I would say, 5 to 8 years. And so the way we treat diabetes now is not the way we used to treat diabetes in the 1990s, for example. And so really trying to get providers on board with some of our newer treatments, this update to the registry will really allow us to do that. So we can look to see how people are prescribing and really be able to recommend different types of medication and be able to provide some medication nudges. And we're also thinking about different ways of remote patient monitoring systems, which we've kind of delved into a little bit, but I think there's an opportunity to lean into that as well.
What does that mean, remote patient monitoring?
So where a patient can monitor patients currently monitor their finger sticks at home, but as well as they monitor their blood pressure, but they have to manually provide that information to us. There are systems that will manually upload, upload automatically into an EMR. As well as we have things like continuous glucose monitoring, which will allow a patient to not have to check their finger stick, but will implant and can continuously monitor their glucose and can send it to us. Not necessarily into Epic. A lot of them are into like something separate, but it can all be sent electronically as opposed to provide patients having to manually enter any data. So we're thinking about some other opportunities for that, and similar things apply for blood pressure monitoring.
But even beyond that, I think the like wearables in terms of
Yeah, I was just
activity
thinking.
and like
Yep.
calories.
Activity is another one. Yeah, we haven't tackled that yet.
So I have a couple of comments. You have Treat to Target, the nurses are doing outreach.
Yes.
You have another form of outreach that is happening. We have the pharmacists who are helping with management, and then we have alerts. How does is this expensive? It's very high touch. And we've been increased by a couple of percentage points. How does that balance out? First of all, is it a high expenditure to provide all these outreach? The nurse is doing outreach. There's another form of outreach, clinical pharmacists. Not that I question the value. I'm just looking at the financial side of it.
Yeah, so I think the financial side is probably through value-based payment because we have so many contracts that really focus on A1C lowering. So that's where we get some of the financial gains. But I also think that the nurses, the chronic disease nurses, they're part of our clinical teams. And so that was really like a restructuring of roles. And that did come through getting them embedded the way we did come through Disrupt funding, years ago. But they are part of our clinical teams, and they spend half of their time just seeing patients on the clinical team, and this was carving out. So I think the newest role that we have are really the pharmacists, which
And they're invaluable.
yes, yes.
And then the other question I had in terms of communicating with patients in real time, a chatbot.
Well, we haven't thought about that. We do have, we don't, it's available across our facilities to our patients. We've probably had maybe a couple of thousand patients that have used it now. Not a chatbot, but an app that for patients with diabetes, and that does give them message in real time when they check their finger stick and they put their finger stick result in. It sends them a message in real time, and it's available in Spanish and English, but those are the only two languages. And it will give them instructions as to what to do if their finger sticks are high or if it's low. And so we've had some pretty nice results in that, but it takes a lot to just kind of start it, right? So you have to put a lot of information in, but people can get reminders in terms of like when to take their medication. So it's a lot of startup. It has some startup costs, or energy, not like dollar wise, but energy.
Yeah.
And then, but some patients really love it and they log everything in. And one of the features that I really like about it is if you actually put like the amount of carbs and things that people are supposed to eat, if they're about to go to a restaurant, it actually will tell them like these are the things you can eat in these restaurants. So it has some really nice features. And yeah, we're hoping to expand that in some other populations as well. Yeah.
I think the technology possibilities are huge here. I mean, I actually had written down a similar question to what you asked, Michelle, is how, is there a way to kind of because intuitively I feel like this has to be good from a financial perspective, right? I mean, there's costs for sure, but the outcomes, as we've always said, is going to improve our financial picture as well. And I don't know if there's any way to capture that.
Yeah, we can definitely try to look at it much more robustly than what I explained, yeah.
Like heart attacks, strokes avoided.
Right, exactly.
Yeah.
Yeah, right.
So this is one of those topics that I feel like I have a paper on it, but I won't go there.
Share it.
But the only thing I'll say is I find it very interesting that you had like a lot of different 1.7 percentage points sounds like a lot,
It's a lot.
and it's like a 20% drop on like somebody with an 8 or something, or
Yeah.
And then, but you mentioned outreach going up 25 to 50%. You mentioned the one that caught my eye was also like getting doctors to do certain things a certain way, which I'm sure it's a lot of fun. So
Work in
I'm
progress.
curious as to like what do you think is causing it more? Is it standardizing things so that everybody that is doing primary care here does it the
Yeah.
same way, or is it the outreach piece, or just 25% of each, or what?
Yeah, I mean, I do think that there's a really sophisticated statistical analysis that needs to be done to answer that. I don't know if anyone can help us with that, but no, but I really think that that you do need these multi-component interventions, right? The outreach, I think you have to do. Our patients have lots of things going on. Diabetes is, or management of their illness is not necessarily top of mind for everyone, and they miss an appointment. So people who are regularly keeping their appointments, fine. But then you miss an appointment and trying to get back into the appointment, trying to reschedule that primary care appointment once missed, could be impossible sometimes. It's really challenging. So that proactive outreach is really important because it tells patients, we need you to come back in. We know that you missed an appointment for whatever reason, and now we're going to be proactive about rescheduling you and getting you back in. So I think that if I had to guess, I think that that's probably one of the key. And I think having pharmacists as well as nurses who can try to get over that clinician inertia in prescribing, because sometimes it's just that, you see the patient, you don't have their lab result right away. You may not have it right then and there. And then there are multiple other things that might be going on that you didn't really get to focus on the diabetes management because they came in with like 5 other problems. And maybe you didn't advance their medication on that particular visit. So I think having other people that can see the patient, like pharmacists, like chronic disease nurses, that can really work with the PCP to overcome the clinician inertia and prescribing is important.
And just 15 seconds, do we have enough clinical pharmacists to do that work?
I don't know the answer to that. I don't know if we have enough because those numbers come under AmCare, but I can certainly find out whether or not we have enough.
It's certainly true that it's easier for us to recruit them.
Yeah.
They're not in shortage because commercial pharmacies have all gone to filling bottles with machines, which is as it should be. And so then there's a larger group of pharmacists who are available for clinical work now and who are interested in clinical work. And the pay is not as high as a physician, so we can afford them. The key thing is in order for the economic model to work, it can't be in addition to. Right. It can't be that there are pharmacists to consult because then you just added an expense and you're getting the same revenue. So that, but if you transfer the visit and bill it as a visit, so that someone missed the visit with me and, you know, then got a pharmacist visit, and that visit is billed, then the economics of it work, and then we can hire as many as, you know, we want. It's the question of using them appropriately. I can't underestimate, at least based on my own practice, there is a group of people who love these tools and use them really well. And there's a group of people who are very far from being able to use these tools, and it includes all the cultural things we know. One of the most useful things I've learned to do is to explain to people how I'm giving them the smallest possible dose, because there's so much medication resistance. So like a standard thing for me to say is, I'm giving you this, some people are taking 4 times as much, because they split the pills. I give them the tiniest pill and they're going to take half of it, because there is tremendous belief in the community of people we're taking care of, a lot of suspicion about pills, a lot of disbelief about medicine. And then that's in my experience, especially true in the Latino and the African American community. And in the Asian community, there's a lot of belief that medicines are for cure. And right, there the issue is people are happy to take it. They'll take as much as you want, but then they just stop, right? Because if you hadn't cured the issue, then the medicine must not be any good, right? So, I mean, there is so much culture. Right, it's very different than working with people in a different socioeconomic strata who, you know, are not dealing with housing and other complicated problems, and who really have, society has sold them the model of American medicine. Not everyone believes in the model of American medicine, right? We talk about always trying to achieve these high things, but these high things require that you believe in the model. And not everybody believes in the model. A lot of people really, do you agree on?
Yeah, no, I agree.
So, you know, it's that I like what Nicola had said. In my idea, where we have tools for everybody, right? If you're the conscientious person who can follow the Noom-like, you know, texting, we got that for you.
Right.
If you're the person who needs the outreach worker just to come to get you to take 1 metformin a day, because that's as much as you'll do, then we have that for you too. And that's our best shot.
But isn't there a component too on the medication point on just health, wellness, and diet and lifestyle and those, and is that part of the outreaches?
Yeah, absolutely. I mean, medications, as well as diet, as well as exercise, you know, so our nurses, our pharmacists, they all educate around those things as well. We have dietitians in some of our facilities that our patients will see. So I think that's all foundational. But for diabetes, a lot of it does come down to medication management on top of diet and exercise.
Average person doesn't feel bad with an elevated sugar. I mean, if you get to 400 or 500, they might feel bad. But the people we're talking about who are, you know, routinely running 200, which will ultimately hurt their kidneys and heart and shorten their life, they feel fine. So that's what I mean about, you have to buy into the medical model. You have to buy in that you feel fine, but I'm telling you your glucose is 225, and therefore just taking this one medicine isn't enough. Now I need you to take this second medicine. And maybe now I need you to take this third medicine. Now I need you to inject this other thing. There's just not buy-in, and so we start with our patients with just trying to convince them of the thing that people in other practices just assume. That people are coming to you, control my sugar. My sugar is 225, do something about it. That's certainly not the reality of the people I see at Gouverneur.
What's the interaction with weight, though? The patients coming to you to lose weight who happen to be which is the hardest, to manage diet and weight or implement medication?
It feels like a loaded question, but I mean, I think both are challenging. It depends on what the patient wants to focus on, right? So I think there are patients that want to lose weight and will do different things with their weight loss, for their weight loss that maybe they weren't as motivated to do for their diabetes, and vice versa. For some people that they're fine with their weight until they tipped over and developed diabetes, and now it's just like, oh wait, now I really have to do something about it. So it really depends on the patient. Now we have medications. A lot of the medications that we use for weight loss are actually also medications that are used for diabetes. So it helps now that we can treat patients for diabetes and also help them to lose weight at the same time. That's where we are now. 10 years ago, even 8 years ago, I would say many of our medications for diabetes actually caused weight gain. And so it worked against us, right? But now we actually have medications that work in the correct direction. Both can lower A1C as well as lower the weight. So they can be very helpful.
Okay, so I gotta bring the meeting to an end. Thank you so much. Very informative discussion on our diabetes management work. And on that note, is there any old business or new business to come before this committee?
We'll bring the same analysis for physicians leaving underrepresented minorities. Can't promise it for the next one, but we'll work with our affiliates and see if we can recreate that same analysis.
And could I just make a request to see, is it possible to see a little bit of trend history? Maybe like
We could make them into
annual,
graphs. Yeah.
not just on the rate, but on the dashboard, basically.
Yeah. Yeah. Yeah.
Maybe like
Like a
2018
run chart,
to
so,
2020 now, like to see
Yeah.
kind of through COVID and how the different metrics have moved and changed.
Okay, we'll make that our deep dive, either on the next one or the one after that.
Yeah, maybe in anticipation of your
Yep.
annual update.
Exactly.
Thank
Okay.
Okay, thank you. Meeting adjourned.
Thank you.
This meeting is no longer being